Yeah, thank you. No pressure. Yeah, thank you. My plan is to save about 5 minutes at the end for questions. I was joking in the back that I have just enough time to tell you nothing about DBT. So I'm going to do my best to give you kind of really like a broad overview about the therapy or the theory behind DBT and the components that make up the therapy. So if you have questions about getting further training in DBT, you can ask me afterwards. And if you have questions about referring teams, also please feel free to ask me about that afterwards as well. So, what is DBT? DBT stands for Dialectical Behavior Therapy. It was originally developed by Marsha Linehan in the early 90s, and then some of her colleagues adapted it for adolescents a couple of years later. One of the greatest things that's happened recently with Adolescent DBT is we actually have an official skills manual for it now. I think I did a similar training to this 4 years ago. We did not have a training manual, and now we do. And you can easily find that on Amazon. And so the goal is to help people who kind of have chaotic and painful lives, feel suicidal a lot of the time, may hurt themselves deliberately in order to change how they feel, have a lot of issues with mood, depression, anxiety, any of that, despite having other good treatments in the past. People who feel like out of control of their emotions, and also people who feel painful and empty. This was originally developed for borderline personality disorder, but what they found is it actually helps with a lot of other different disorders. So PTSD, depression, anger, anxiety, eating disorders. Most of the research has been done with bulimia, the efficacy, but they're getting better research for anorexia as well. You're going to be hard-pressed to find a residential eating disorder that doesn't have DBT as part of their training. Substance use disorders, and also any kind of aggressive or violent behavior. I am confident you all have teams that you see that fit into one, if not multiple, of those categories. One of the things that she did was really think about borderline personality in a different way. There's a lot of stigma attached to a BPD diagnosis, but Linehan really broke it down into the different kind of problem areas for people. And what you'll notice is these problem areas come up in a lot of other disorders, not just borderline personality disorder. So, you have the emotional component, so having that affective instability, so having moods all over the place. I think that's just a state of being a teenager, is having moods all over the place. Having problems with anger, a lot of like cognitive things, so dissociation, a lot of that like all or nothing type thinking. With the relationships, a lot of like relationship instability. A lot of the kids that we get in our program, a lot are in foster care, have had disrupted homes. Even if they are with their parents, there's usually a lot of fighting between the teen and their parents. And so we work really hard to work on the communication between parents and children and foster better relationships between them. Behavioral stuff, so intentional self-harm or impulsivity. This come up in a lot of different ways. I'll get kids who like run away. I call it like running away because they like leave for a few hours and then they come back. And then with self, so they talk about it as emptiness. In teens, it's more of like boredom or bladness or not really feeling connected to who they are as a person. The theory behind DBT is this biopsychosocial theory. So her idea about these things is that you have a biological component, you have a social component, and these two things added together lead to that pervasive emotional dysregulation. So the bio part can be just like genetics or heredity. So this person, just by the nature of them being themselves, is more sensitive. So that means that they have a lower threshold before they're triggered. The reactions they have are a lot more intense. And then also it takes them a lot longer to kind of return to like normal or their baseline. Other things that can come up with that are that like impulsivity. So that difficulty with restraining themselves or kind of holding back, and also a lot of like mood dependent behavior. So that kind of stuff like gets in the way of their goals, and they feel like they don't have control over what they're doing. They feel like their emotions dictate everything. With the invalidating environment, it's important to note that this could be any environment. It could be what you would deem to be, you know, an unhealthy household, but invalidating environments can also come up in like a typical family household. So when I tell people about this, I'll usually use an example of, you know, say you have a family with multiple kids. One of the kids has ADHD, right? So they need a lot more attention than the other children. But they have two parents who work all day and have a lot of stressors and don't maybe have all that time to give them that special attention that they may need. These parents aren't intentionally setting out to be invalidating, but they may be invalidating at times on a consistent basis, you know, and then that can foster those feelings for that child, right? So that child might need an extra 20 minutes, but the parents are stressed out and they said, you know what, I can't do that right now. Can you please go try to figure out that for yourself? That kid gets that message enough, and it instills kind of that voice in themselves that they should be able to do better, things should be easier, problems should be simple to solve, and that's part of the invalidating environment. Other parts of the invalidating environment are the like intermittent reinforcement of escalated behaviors, right? So if you have a kid who is throwing tantrums, right? Well, sometimes they respond to that, and then other times they don't. And that can increase not having that consistency. And who hasn't intermittently reinforced something, right? It's like sometimes you're like, I just want you to be good, so I'm going to give you this thing, even though I know I probably shouldn't do that in this situation. There's also things like if there's a lot of stress in the household. So, you know, I see families all the time that have stress, financial stressors. When they have kids who are acting out in school, that brings up a lot of stress in the household. So that's a very common thing that comes up in that invalidating environment. So one of the things I'm really clear about when I'm educating patients about this is this doesn't necessarily mean that like you're a bad parent. These are normal things that come up, and along with the biological parts, it can lead to having these problems. So I really try not to sound like I'm being judgmental. It's just kind of trying to identify the problem areas so that we can work on those in the individual therapy. So the treatment frame, the most confusing part for people in DBT is like the dialectical part because that's the part that's like new, and you probably haven't heard of it outside of DBT. And so a dialectic is really trying to synthesize extremes. And that'll be something that I'll highlight more as I keep talking. And so with the dialectic, we're balancing a lot of different things. And in the DBT treatment, what you'll see is we have validation and acceptance strategies, but we also have like cognitive behavioral change strategies as well. And one of the things that Linehan noticed when she was working with individuals was if she validated too much, right, then people will get upset and say, well, you're not helping me because my life isn't getting better, right? But if she focused too much on change strategies, then it's, you're not listening to me, you don't care about me, you're just focused on trying to get me to do what you want me to do. And so she, you know, came up with this idea of using the dialectic to kind of synthesize those two things and have the right balance of those two components. So that's a big part of what we're doing with the dialectic is really like focusing on situations and saying, what's needed here? Do I need to be a little bit more this way, or do I need to be a little bit more that way? And patients will know if you choose the wrong thing. So we have a lot of assumptions in DBT. One of the things that I really enjoy about DBT is that, you know, the burden of the treatment is really on the therapist. It's not on the patient. And so her rationale for that is, if a patient had cancer and they went and got chemo and the chemo didn't work, you wouldn't say the patient failed the treatment. You would say the chemo didn't work. And so she likes having that same mentality about mental health treatment as well. And so if something's not working, I'm always working really hard with the patient to kind of figure out what those things are. What are the things that I can be doing differently? I can help them to do differently. And I think that it fosters less judgment for me as a therapist when things get really hard, and forces me to be a lot more collaborative with my patients. So we talk about the fact that patients are doing the best that they can, that they actually want to improve, but even though that's also true, they also need to work harder and be more motivated for treatment, and that's where that balance comes in again. And that the lives of people, of suicidal individuals, are unbearable as they're currently being lived. So these are people who are in pain, and a lot of the reactions that they're having are because of that. And we know that, you know, a lot of times when we don't have healthy coping skills, we learn unhealthy things to do to cope with that pain. And we also assume that they must learn new behaviors, and that also what I talked about, they can't fail in DBT. The dialectical worldview, I kind of touched on that a little bit. We always think that like everything is connected to everything else, and that change is constant and inevitable. So that's something that's always going through my head with the patient. And one of the things that I'm working really hard to help them with is learning how to respond better to change. You know, nobody likes change. And that's something that comes up in almost every therapy session I have. There's been some change that's caused some reaction in that person, and how do I help them cope more effectively with that? And letting them know that they're not operating in isolation. Their behaviors not only affect themselves, but everyone around them. The fundamental components, I talked about that already. Dialectical dilemmas. I'm going to try to spend a couple of minutes on dialectical dilemmas, because this is another component that comes up a lot in individual therapy, and it kind of denotes that need to synthesize and find that balance. And so one of the things she found in her research is that people tend to jump between extremes, right? So if one thing doesn't work, well then obviously the opposite of that thing will work. And we know that typically that's not the case, that's not true. And so we're really trying to find the middle ground between these things. And so we have these different dialectical dilemmas that are associated with each other. They're the extremes for each other. So you have like the emotional vulnerability, which is kind of what I talked about when I talked about the biological component, where you have a person that's just inherently more sensitive. It's just a fact, they're more sensitive. And because that happens, and because they experience more intense emotions, this can lead to a lot of problems for that person. And so it's interesting because even positive emotions can lead to problems for that person. And so, you know, an example I like to use, something probably happens to me every other week, is someone will start dating someone, or they like someone, right? And if you like someone, obviously you have to spend every waking moment in constant contact with that person, right? And so then it's, I'm going to send this person 1,000 text messages, Snapchats, Instagrams, all of this stuff, and then the person's like, whoa, 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 right? Now they don't want to talk to them anymore, and now they have to experience pain because they've kind of come at it too strong or been too intense. And so that's the kind of problems that like people who are emotionally vulnerable find themselves in. Now the opposite of that is this like self-invalidation that can come up, where, you know, some people will go from being that way to saying, well, I'm stupid for feeling this way. I shouldn't feel this way. So they'll try to just not have emotion. And that doesn't work very well either. You know, and a lot of times they get this from that invalidating environment, right? Like, why can't you just like chill out? Or why can't you just do that by yourself? Or, you know, and they'll internalize that voice, and then they start berating themselves in the same kind of way, and they try not to be emotionally vulnerable, but that doesn't work for very long. So then they swing back to the other pendulum. We also have the unrelenting crisis and the inhibited grieving. You'll also see this in the literature as inhibited feeling. Unrelenting crisis, I think of that as kind of like the crisis of the week. Every time they come in, it's this new thing that happened, right? You know, I had these 5 girls who, like, you know, they got in a circle around me and they were bullying me, and then next week they're like best friends with these 5 girls, and then the following week they're bullying somebody, you know, so it's a different thing like every single week. And so that can kind of be the unrelenting crisis, and they can also kind of keep that going. So one of the things you'll find with this is that people who get stuck in this, because they can't tolerate pain, what they'll do is kind of act out in certain ways that create further crises, right? So I am mad at my parents, so I go up to my room and I cut, right? Which then creates a whole new set of problems. Now my parents are putting me in the hospital. I'm out of school for 2 weeks, you know, or whatever, and so it kind of keeps that loop going. The opposite of that is inhibited feeling, which basically says because the person can't deal with pain, what they do is they inhibit those feelings, and that keeps them from habituating to whatever the problem is, right? And so that's part of how we get over pain over time. So one of the reasons let's call inhibited grieving is you can kind of think about like the grief process, right? Like if you lose your mom, like the amount of pain that you feel doesn't go away, but you get used to that pain over time. And you habituate to it, and it doesn't trigger as much immediate affect as it did when it first occurred, right? When you don't allow yourself to go through those processes and feel those feelings, you never get to have that happen. So each time it comes up, it's just like it happened the first time. So we have our longest section is on emotion regulation and helping people learn how to effectively cope with emotions because of that. You also have the active passivity versus apparent competence. So active passivity, for me personally, is the one that causes me the most stress in the therapeutic environment. So active passivity is where a person will kind of passively act like helpless, as well as also demanding that you fix whatever the problem is. You know, like, I can't do it, it's your job to figure it out and make me all better. And that can be the one that's the most frustrating. The opposite of that is this apparent competence where patients present as skillful. I've seen so many people, the first time I see them, I'm like, why are they in here? Because they know all the right things to say. It seems like they're very knowledgeable, but then I'll get like the phone call the next day that they're in the hospital because they cut or something, you know what I mean? But in front of you, they seem like they know. And so it's balancing that, you know, you don't want to treat the patient as helpless, but you also want to make sure that you're providing them with enough support so that we're not swinging between these two things. You know, and this comes up a lot, you know, as I'm teaching people skills. One of the mistakes you can make as a clinician is assuming that that skill generalizes to all situations. So if I'm teaching someone about interpersonal effectiveness and I notice, like, man, they've been doing a lot better at school, like communicating with their peers and everything, they've got this. But then something comes up where they have to ask their parent for something, and then we didn't troubleshoot it, and now all of these old behaviors are coming up, and then I get the 10 p.m. coaching call like, I hate my mom and I'm leaving here, she's stupid, you know, and then we do the troubleshooting on the call, and now it's fine, you know. And so it's really being careful to like not make that assumption and kind of role play and say, how are you going to address this with your mom? How is this different than it is with talking about things with your friends? What other things might come up? It's very important to do those pieces. There's a whole host of dialectical strategies that come up, and so remembering that this is all about like creating that sense of balance. I won't go into a lot of detail on all of these, but entering the paradox is kind of where you kind of get into that uncomfortable moment with the person and you look at the truth on both sides of an issue. And you're not doing it with the goal of like picking a side, it's honoring the truth in both of those perspectives. So that comes up a lot when you're dealing with like the parent-child dynamic, right? The parents have their truth about the situation and the teenager has their truth. And one truth is not better than the other. And that ends up being like a really effective skill. And we talk about other skills in the walking the middle path, but I find that if a person gets good at doing this on their own, they can validate each other a lot better. And they can have actual discussions versus kind of this unhealthy argument pattern. You know, because I've had teams actually say to parents, I can understand why you don't want me to be out until 12 o'clock. And the party goes until 12, and I really want to be able to go. What do I have to do to be able to do that? We use a lot of metaphors in DBT. I typically come up with a lot of my own. That's one of the differences. I don't know if you've had any exposure to ACT therapy, acceptance and commitment therapy. They have like their own inherent, like, you get a whole book on like ACT metaphors. They don't have that for DBT. You kind of come up with your own, steal from other places, so you can steal from those ACT metaphors, use them in DBT. The devil's advocate, I use that a lot. Depending on the relationship I have with the person, I'll warn them that I'm going to do it. Like, okay, I'm going to be the devil's advocate right now. Extending is one that you use when you take a person more seriously than they intend for you to. So this comes up, the most common example is when I get people who are kind of gamey about being suicidal, so they'll come in and be that way, and I let them know, well, my #1 goal is to keep you alive. So I'm just going to go ahead and call 911 right now since you can't contract for safety. I get a lot of people who are motivated not to go to the hospital, so then they'll pretty quickly get on the program of, okay, like, I'm not really, like, you know, I know what to do, and here, you know, I'm willing to sit down and, you know, do a safety plan and all of that kind of stuff. And so that's what extending is. Activating wise mind. In DBT, we talk about the 3 states of mind. So we have, like, the extreme of the emotional mind, the extreme of the reasonable mind, and then the synthesis of those 2 things are the wise mind. And so most people are going to trend towards being an emotion mind. I get 1 or 2 that are on the other side, but 8 out of 10 are going to be more emotion minded. And so what I tell people is nobody lives in wise mind. Like, I don't live in wise mind. I can get emotional. And so what I tell them is, like, think about it like a neighborhood, right? You want to be in a neighborhood that's close to wise mind so that when you need to commute, you can get there pretty quickly. Like, you know, and so that's kind of like what our goal is with these types of things. And over time, like, you can see that people do kind of move closer to that. And so one of the ways that you can activate wise mind is, the easiest way I found is doing pros and cons. It's like, okay, you can go and punch that person at school tomorrow. Let's talk about the pros and cons of that. You know, and kind of going, and that activates that logical mind, which can kind of pull that person towards the center. Making lemonade, that's very much to, like, you know, when life gives you lemons, make lemonade kind of thing. And then the allowing natural change, that's a big part. You know, I think sometimes, I'm going to say for myself, sometimes I struggle with that because I'm like, I can see where we need to be. Like, I want to help us get there, you know, so quickly. But there's some kind of things that you really do have to let, like, marinate, right? And, you know, allowing the space for things to happen gradually over time is one of the greatest things that I think that we can do, because people don't operate on our schedule. They operate on their own schedule. The change strategies, there's a lot of them. You're probably familiar, if you know CBT, you're probably familiar with a lot of these. One of the ones that I'll say that we do a lot that I never did when I was doing just straight CBT is the behavior chain analysis. And we do those all the time in DBT. And so basically what you're doing is you're getting, like, the topography of, like, a problem behavior. So, like, if someone comes in and they tell me that they've cut, I'm trying to look for the vulnerability factors that led to them cutting, the specific situation that led to them cutting, and sometimes that may be something internal. It may not be the external situation. It may be a thought or an interpretation that they had of that external situation. And so that's why you have to be pretty detailed with your behavior chain analyses, because if you're not, the solution analysis where you're trying to come up with skills to use, it's not going to work. So if you're targeting the relationship with the mom and really it's a thought that they had, then that situation is going to probably happen again in the future. So when you do the chain, really what you're looking at is where are places that we could have inserted skillful behavior that would have kept us from getting to the problem behavior of cutting, right? And so that's what we're looking for when we do the behavior chain analysis. Validation or acceptance strategies. We do a lot of this in DBT. In DBT, we talk about the 6 different levels of validation. And so the first being just like staying awake, just being there in the moment with the patient. Accurate reflection, articulating those unverbalized emotions or thoughts that a person may have. Validation in terms of past learning or biological dysfunction. So you're really there, you're telling the person that it makes sense that, that you respond to anger that way because your father also responded to anger that way and you kind of like learned that behavior. So that's the type of validation. So validation in terms of like the present context or the normative functioning. So really what you're doing there is letting the person know that that's a justifiable behavior. Like, of course you responded that way. Like, who wouldn't respond that way in that situation? And then radical genuineness, which is really about just being like a human being with that person in the moment. And kind of, I think about it as kind of taking away that like I'm a doctor and just being like Monica with that person and really saying, I hear you and I'll sit in this moment with you. It's not about fixing anything. So shifting gears, we have a lot of different treatment targets in DBT. We have a hierarchy that we follow, and this is throughout the treatment, the way the treatment is set up as a whole big picture, and also how you handle things in the individual therapy session. So the first treatment target is harm. So any sort of thing that is like kind of like a threat to their life. So suicide attempts, self-injurious behaviors, if there are attempts to harm other people. Also, this doesn't come up as much with adolescents, but if a person has, for instance, a medical condition and they're doing something, right, that could lead, so if I had a person who was like diabetic and they're like not taking their medicine and like eating Frosties all day, that's a life-threatening behavior, and I'm going to want to target that behavior. And so those are all the things that we're going to look. So they fill out a diary card, and I'm looking for these different areas. Because if any of that comes up, that's going to be the first thing that we're going to talk about. And we're going to talk about it until we don't need to talk about it. So if it takes the whole session, it takes the whole session. And patients will try to get you to talk about whatever the crisis of the week is. But it's important to stick with that. Because number one is stay alive. Everything else is secondary. We also talk about therapy interfering behaviors. So this is anything that gets in the way of the patient getting the treatment that they need. So refusing to come to their therapy, not taking meds, being verbally harsh to therapists. I have a patient who keeps a journal. We have since worked on this, but for months, she would write in this journal, Dr. Johnson is cold-hearted and she doesn't care about me, and like just stuff like that. And I read her diary card and then I do her journal. That's part of like our process. And so like I'm reading like how terrible of a person and therapist I am, and then going into the so we created like a target hierarchy, and we worked on each of those things in addition to some other stuff. So being late, not paying attention, refusing to do homework assignments. We give candy at our DBT group, so tell people that. Like sometimes candy is a motivator. So like when people do their diary card and their homework, they get candy. That's their reinforcement. And also like just frequently withdrawing from treatment can also be a therapy interfering behavior. And this part is, again, number 2, because the first thing is stay alive. The second thing is actually getting the help you need to get better. And then the third is all the stuff that the patient's going to want to talk about, which is like the quality of life interfering behaviors. So their mood, relationships, issues at school, all of that kind of stuff. That's like the third target. And so, what I find is depending on the severity of the case, when we're first starting out, a lot of our sessions, maybe the majority of it is like target 1 type stuff. But over time, what I'll notice is it's mostly target 3 type stuff, because the person is using skills and they've gotten a lot better at doing things. So it really does make a big difference. And then we also have like the 4th target, which is the skill deficits. and you're going to get that through the group. So you're going to be learning skills in each of these 3 different areas, which I'll talk about more in a minute. So the components of like a comprehensive DBT program, that's going to include, like in the traditional model, it would be weekly individual therapy, weekly group, there would be a consultation team for the clinicians, and then that person would have 24/7 coaching calls, which for most people just makes your throat clench up when you hear that, but it's really not that bad. I'll talk about it. So with the individual therapy, ideally this would be conducted by a DBT therapist, but 90% of the time here it's not conducted by a DBT therapist, but we do try to keep the therapist informed about what's going on. So, you know, and releases are signed and all that kind of stuff. So the purpose of individual therapy is to reinforce skills and to generalize skills. So what I tell my patients is, you go to group and you learn the skills, and then I'm going to tell you how to apply those skills in individual therapy. You know, and some people say, well, why can't I just do it all in individual therapy? And I try to explain to people, 45 minutes really is not that much time. You know, it's going to take 20 or 30 minutes to teach the skill, and then now we've got 10 or 15 minutes to talk about other stuff. And it can really slow down treatment and make it a lot less effective. I'm also working to identify barriers in that person's life that get in the way of them using skills and helping them problem solve around those, addressing any treatment interfering behaviors, and then fostering that therapeutic alliance and relationship. And also keeping that person motivated through my own excitement about DBT. So I've got to be like, because DBT is hard. Like, their lives are hard, but the process of changing those lives can be just as hard, if not more hard for them. So I have to keep them motivated and be their cheerleader through the process. The structure of the sessions, it always starts off with a warm greeting, and then it's the diary card. And so if you were to see one of my sessions, like my patients like sit down and either they automatically pull out their diary card or they pull out the excuse for why they don't have their diary card because they know that it's coming. And so if a person doesn't have a diary card, I will usually make them fill it out in the session. I've got some patients, mostly adult patients, who they know, and so they'll ask the receptionist in front, like, do you guys have any diary cards up here? Like, so I can fill it out and pretend like I did it before I got here. So yeah, so they know. They know the process. We're going to be identifying the target. So I'm going to be following that target hierarchy. I'm looking at the diary card, and we're making that agenda about how the session needs to be structured. The structure is like so important in treatment. I feel like, you know, outside of the therapeutic alliance, structure in people's lives who don't have very much structure is sometimes one of the best things that we can do for them. So they kind of know what to expect in this situation, and so they know here's how what's going to be targeted, and here's what we're going to do. So I have some patients that come in and already know. I know I got to talk about this. I know I got to talk about that. You know, if we need to do any chain analysis, we'll do those, and then you can reinforce them with like free time. So like, say there was like a suicidal thing, but they've been really like willing to safety plan and implement skills. So we're going to work on this, and then we'll have 10 minutes at the end to talk about this other thing you want to talk about. And then you reassess like urges at the end. So, and this could be like suicidal urges. I will also, if we've been having problems, assess about urges to quit therapy at the end as well. Like, where are you feeling now? So that's one of the things on the diary card. So a person may come into therapy a 4 out of 5, and I may ask them, well, where are you at now? Is it still 4? Is it higher? Is it lower? Where are we at? Skills training. So this is a weekly group. It happens for 2 hours. There's 2 facilitators. In our group, it's myself and Dr. Walton. There's usually 6 to 8 families. The patient needs to attend with like a caregiver. We very loosely define caregiver to anybody who has some, you know, why am I losing words right now? Anyone who has good contact with that person. So not someone who they're going to see once every month, but somebody who has pretty consistent contact with that person. Because you really want the caregiver to be someone who can kind of reinforce things for that person. So we had someone come through group who came with like their big sister, and I mean like big brother, big sister, like, you know, because that person had weekly contact with them, and the teenager could access them by phone, and so that person could reinforce skills with them. So caregiver is very loosely defined. There is a 75% attendance requirement, and that's just because if you're not coming to group, you're not learning the skills. And so the purpose is to decrease therapy interfering behaviors, increase the skill acquisition, and also decrease any other behaviors they have that destroy relationships or therapy or anything. Consultation team, that's for the therapist. And so I let all my patients know, like, I go to this consultation team. Sometimes we bring up cases, you know, but, you know, really, they say consultation team is like therapy for the therapist, because working with patients who meet a lot of the criteria for DBT, it's really stressful. I've had moments where I have believed that I was a cold-hearted, you know, therapist, because I was like, you know, what am I doing? Like, why isn't it, you know, working? But consultation team is great about providing that support and suggestions and like validating you and all of those things that keep you motivated as a therapist. We all fill out diary cards. So we have a motto: we don't ask our patients to do anything that we wouldn't do ourselves. So we practice mindfulness, we fill out diary cards, and we talk about those on the consultation team. But yeah, so we do that. We discuss cases. There's an educational component, so we stay on top of the research on DBT or anything that would enhance us as DBT therapists. And, you know, it's one of my, like, favorite things. We don't have our next one until January 30th, and I miss it. Coaching calls. So this is the thing that, like, typically freaks people out. It's honestly not bad. Teenagers don't want to call you. Like, they don't. Usually, I'm like scheduling a call. Like, you're going to call me at 8:30 just so we can, like, practice this call and kind of get all the weirdness out of the way. And so if you do your due diligence and orient a person to coaching calls, I personally have not had any, like, problematic coaching calls, because people know they're usually not going to be longer than 5 or 10 minutes. They know when they call, they need to be ready to tell me specifically what the problem is, so that we can instantly get into problem solving, what skills they need to use to help in this particular situation. The family can call, like the mother, yeah. If like the parents or somebody need to call, yeah, they can do that as well. Yeah. So yeah, we'll give out the number. Like, every therapist has their, like, limits about things. With me, I usually wait about 4 to 6 weeks of a person, like, coming, so I know that they're committed, and then I will give the coaching call number. And so that's my personal limit. Other people will give it the first therapy session or whatever, but that's normally how I operate. And so then they get it. I personally don't like text messages, so I don't do text messages, but there are other DBT therapists who do text messages. I just find that, like, text messaging takes a lot longer than just, like, calling. There's just a lot of, like, back and forth, and you could text for an hour with what you could do in, like, 3 minutes on the phone. So yeah, so the parents can use that coaching call, the teenager can use that call. If you have someone who really struggles, like, I'll have, like, a coaching call worksheet that I'll give to the person that they fill out before they call to help them, like, be focused if a person does struggle with, like, being focused on a coaching call. And it's important to note the differences between a crisis call and a coaching call. A person doesn't have to be suicidal or ready to cut to call you. This is any time they're having a problem using a skill. So they could call me and say, hey, you know, I have this thing that I want to talk to my friend about, and I don't know how to do it. And, you know, they could call me to get coaching on how to address that situation. If you set it up for them to be in crisis, well, then they'll just be in crisis every time they call you. And you're trying to help reduce that, not reinforce that by giving them extra contact every time they are feeling suicidal. So yeah, and so I also have people worry about the calls like coming at like 2 a.m. I've never had that. I explain to people like, look, you can most definitely call me at 2 a.m. if it's necessary. If you're about like thinking, oh, I'm going to go cut and it's 1:30, pick up the phone and call me. Just know it's going to take me a minute. Like I'm going to have to like, I'm not going to pick up the phone and be like, yeah, I'm ready. Like it's going to be, those wheels are going to turn a little bit slower at first. So I'm just very like honest with people about that. I let people know like, if I'm, doing something, I may be unavailable. If I'm in a movie and I don't have my phone with me, I'm not going to be there. That's not your excuse to then go do that thing that you're thinking about doing. This is where the contingency management, comes in. Like we're going to have alternative plans for that kind of stuff. But if you really orient people well, the coaching calls are really successful. I find that most of the time, I am so happy that they called because then we work on it, and then when I see them at the therapy session, they're like, oh, I did that thing, and now my life didn't explode. So now, and so now it can go better, and they can see how well these things can actually work. I talked about all that. I get ahead of myself sometimes. So with the different modules, so we have the module of mindfulness, and so that helps with that problem of like confusion about yourself. So like kind of not knowing what's going on with you, what you feel, and all that kind of stuff. And so I tell people, if you don't know like what the problem is, well, you can't pick a skill to fix it, right? Mindfulness helps with that a lot. It helps to build your awareness of what's going on inside of you, but also build your awareness about what's happening outside of you. So many people don't understand their emotions. They misread or misinterpret a lot of things in their environment, and mindfulness helps them to be able to do that better. It also helps you to be able to handle change better, have more of that acceptance, and to be able to sit with things that are uncomfortable. One of the mindfulnesses that we'll do like occasionally is I'll bring in ice, and so everybody has to hold ice in their hand for like 1 minute, just to prove like I can sit here and be in pain, and that's okay. Like I can be mindful about it, and if I use my non-judgmental stance, then it's really not as bad as it could have been. And so, we go through all of that kind of stuff. And, mindfulness is like one of those, like outside of DBT, it's like the big thing now. I think it was on like the cover of Time magazine. They were like, mindfulness. So, for impulsivity, so acting without thinking, we have the distress tolerance module. So that module is all about getting through a crisis situation without making it worse. And so we teach a lot of different skills that help a person to be able to not react poorly. And so I tell people distress tolerance isn't for like everyday problems. It's for that like high stress, and it's whatever that person defines as a crisis. Because what I think is a crisis and what someone else thinks is a crisis is a totally different thing. So we teach people how to use distracting skills, how to do things to improve the moment. Dr. Walton will talk about how like she doesn't like needles and how she uses improve the moment anytime she has to get a shot. And so she will just like imagine herself on a beach, and she'll do her deep breathing, and before she knows it, the shot is over and it's fine. And so we teach, kids how to do all of those things. For emotional instability, we have emotion regulation. This is by far like our largest module. We teach people about what emotions are, what purpose they serve in your life. We teach you how to label emotions, so we give you the vocabulary to communicate to yourself and to other people about what's going on with you. We teach you how to not have mood-dependent behavior, how to problem solve. I mean, there's a lot of things that we do around emotion regulation. For the interpersonal problems, we have interpersonal effectiveness. So we teach skills on how to effectively ask for what you want, how to keep and maintain relationships, or how to build and maintain relationships, and also self-respect effectiveness. So skills that you use so you don't do things that kind of go against your values or your morals in a situation. And then our final module is the walking the middle path. And so this is the one where we really talk about family relationships a lot, how to find those kind of like dialectical balances, how to work on extreme thinking. We also teach them how to validate each other. And we'll typically do a lot of role plays where something will come up and we'll have them work together to validate back and forth so they can get practice with doing those things. We also teach like behaviorism, and parents typically like that more than the teenagers, but ways to reinforce people for doing the thing that you want them to do. And that's it. And I'm on time. Like, what questions do you guys have? Yeah, and so we repeat mindfulness in between each other module. And so mindfulness is typically a week, and so anytime we redo mindfulness, new families can start. So there's a start date every single month. Yeah. No. Mm-mm. No. Mm-hmm. Yeah. Right. Other questions? If they need an interpreter, that would be one. If they had like severe psychosis, like that would be one. I mean, we've had some kids who do have I say a little bit, that's not very but like, you know, that may be prohibitory. But it's a rare situation that we've turned somebody away from group. I wouldn't really worry about that. Yeah. How's it my what? Yeah. Yeah, you know, so we keep a database of everybody who goes through the program. I would say with our adolescents, just because there's also the component of like the parent has to be equally as motivated, 50 to 60% probably graduate who come through. It's higher for our adult group. Mm-hmm. Yeah. 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 I think that would really depend on the individual person and what was going on with them. You know, we have had teens who came through group who weren't on medication and saw improvements with DBT, but again, that's like very individualized based off what is going on with that kid. Yeah. So I would argue that as long as the individual therapist is addressing it, it's being addressed, because you can use the DBT skills for substance abuse. It's been implemented for that. We talk about substances in group, but obviously it's not like a substance program. So if that's an issue in therapy and the therapist is using the skills to help address that, then it would be the same thing. And that wouldn't prohibit a person from coming to group if they were actively using substances. We treat that the same way we treat self-harm, where you don't try to, you know, talk about it in detail and trigger other people to do those kinds of things. Yeah, when they're getting the skills. Yeah, yeah. Yeah, so when you refer someone to the group, we do a DBT intake. And so we will meet with that person, make sure they meet the requirements. If they don't have it, because you have to have individual therapy to be in DBT. If they don't have that, we'll work to get that person with the individual therapist, and if they need psychiatry, we'll try to facilitate that as well. Yeah, and so, you know, their approach to things is a lot different. ACT is based off that RFT. I'm not like a ACT expert, but the theory behind it is different. They do share like the mindfulness components of it, but a lot of the techniques in ACT therapy are different than the techniques in DBT. A lot of the techniques in DBT are grounded in like cognitive behavioral therapy, and you know, ACT is a little bit different from that. So yeah. Yes. Right. There's definitely overlap on that side of it with the mindfulness and all the acceptance stuff. From what I've seen, it's that the other side, the change part that is different. But you know, Linehan and Hayes have written books together, so like there's definitely, you know, overlap. And it's been like there's like those mindfulness-based therapy books, and they've both been authors and books like that. So yeah, there's overlap. Any other questions? Okay. Yeah, thanks.